I'm going to present a complex PCI case of left-hand bifurcation with a little twist. So, my patient was a 70-year-old gentleman, non-diabetic, non-hypertensive, tobacco chewer with a history of old acute coronary syndrome in around 3 years back. And since then, he had angina class 2. Examination was okay, ECG was normal, and echo didn't show any regional wall motion abnormality, EF was okay. So, he was taken for diagnostic coronary angiogram of the left side. It showed a non-dominant left system with left main distal 50% plaque with LAD having osteoproximal 90% lesion, followed by mid near total occlusion after giving a large diagonal. Circumflex was non-dominant, having osteal disease, significant disease, and leading to a left main bifurcation complex of Medina 111 and having a ramus like major OM, which was largely okay. The vessels were extremely tortuous, and the RCA was okay, was normal. So, we went ahead with an idea of having doing a left main bifurcation after having secured the LAD mid lesion. As anticipated, there was severe tortuosity and difficult wiring was anticipated. We crossed with a contraplanar Z-shaped curve in the LAD, and after that the second level of difficulty was encountered in the mid LAD as there was a large diagonal with a near total occlusion in the mid LAD, and it was very difficult to park a wire into it. And so the double lumen catheter crusade microcatheter was used to enter the distal LAD with a Fielder FC wire. It's a tapered tip hydrophilic wire which slipped into one of the septals at the junction of the near total occlusion. Thereafter, the wire went into a small septal branch. It was not going into the distal LAD. So we removed the side branch wire and the double lumen microcatheter and dilated at the point of the critical stenosis with a 1.5 mm low profile balloon at nominal pressures. And finally, the wire Fielder FC slipped into the distal LAD, following which the mid LG lesion was fixed with a sirolimus eluting stent of 2.75 into 22 mm stent. And then thereafter, we wired circumflex, and the osteal LAD lesion was dilated with a scoring balloon of 3 into 10 mm. Then we did the IVUS pullback from the LAD, which showed the distal stent, and the distal stent edge was okay. There was no dissection at the distal stent. The distal stent was optimally expanded and well opposed with a good minimal luminal area achievement in the distal stent. And thereafter, the proximal landing zone of the proximal stent in the LAD was identified with a luminal diameter of around 4 mm in the mid LAD, and the tightest point was observed at ostium of the LAD, which showed a lumen diameter of 2.3 at the ostial LAD, and it was having a mixed plaque with some degree of spotty calcium. So this is the IVUS pullback. Still we are in the distal LAD stent. Some more images of the same run showing the left main bifurcation complex, which osteal LAD, as I've already told. The L circumflex was seen merging at 5 o'clock. The proximal LM was okay, but there was mild eccentric plaque at the LM ostia, which was not very significant, causing a luminal, didn't seem to compromise the lumen. So we decided to go ahead with a step crush technique. We deployed a everolimus eluting stent 3.5 into 8 mm in the circumflex, crushed with a balloon in the LAD across in the left main across LAD, and then deployed a everolimus eluting stent of 4 into 38 mm from the left main towards LAD. Thereafter, we did a pot with a 4 mm balloon in the left main and recrossed the LCX, did a final kissing. and then took a post run from the LCX, which showed the distal stent edge of the circumflex was okay, there was no dissection. The ostium was fairly good, and this is the IVS pullback from the circumflex after the stenting. The stent is adequately expanded. There was slight malapposition in the proximal part, which was handled thereafter. And this is the LED coming up. There was also some malapposition seen in the left main. Then we took a run from the LED also, and it showed the LM stent was slightly malapposed in the proximal part. The ostium LED was okay, and the circumflex ostia was fine. So these are the post images, the final angiographic result. This was then a report was done to address the malapposition in the left main, and then the final IVAS after report was again taken from the LED, which showed good expansion at the ostium of the LED, which was the tightest point, achieving an MLA of 10.9 at that point. The proximal LED was good, had well expanded, and also the left main stent malapposition was addressed. The ostium of the left main was, however, left, and it didn't show any further deterioration in the ostium of the left main. There was some calcium in the LED. So this was the ostium of the LED having the tightest point, then the circumflex coming up at 7 o'clock, and the distal left main. The left main stent is okay, and the ostium of the left main is left as such. So take home points was the careful assessment of the angiogram involving the left main anatomy, with the procedural planning of having a 7 French system via radial using glide Chandler's sheets and a 7 French guiding. In our case, since we had to cross a mid-LED critical disease with a tortuous anatomy, we had to use a taper tip hydrophilic wires with double lumen microcatheters to have the luminal access. And then the intravascular imaging, as in any case of left main, is must for lesion characterization, vessel sizing, and post-stent optimization. Thank you.